Endoscopic retrograde renal access for percutaneous nephrolithotomy, a simplified step-by-step technique utilizing Retroperc. PCNL is recommended as the first-line treatment for patients with a stone burden greater than 20 millimeters according to AUA guidelines. However, in 2019, only 8% of kidney stone procedures in the United States involved PCNL, largely due to challenges with renal access. Over the past decade, there has been a significant increase in the number of urologists performing their own renal access for PCNL, rising from 12.8% in 2007 to 32.3% in 2017. Despite this, many urologists still rely on interventional radiology for renal access, which has been associated with higher rates of complications, including longer hospital stays and increased readmissions. Endoscopic retrograde access technique can further empower urologists to independently perform renal access, potentially improving outcomes. Our objective in this video is to provide a detailed step-by-step explanation of the endoscopic retrograde renal access technique, using ureteroscopy and fluoroscopy to optimize calyx selection and reduce complications. Our patient was a 31-year-old female with a partial left staghorn calculus measuring over 3 centimeters. Flexible ureteroscope was employed to visualize the target calyx, and the Retroperc kit was used for renal access. The nephrostomy tract was dilated to 24 French, allowing for the successful execution of Essers. To prepare for the endoscopic retrograde access technique, a thorough preoperative assessment, including a CT scan, is critical to select the optimal access window and identify the ideal calyx for puncture. We begin by positioning the patient in a Galdackel-modified supine position, which offers ideal access for combined endoscopic and percutaneous surgery. This position optimizes fluoroscopic and endoscopic access. A retrograde pyelogram is performed to outline the calyx anatomy and guide our access. Next, a ureteral access sheath is inserted over a wire to facilitate smooth passage of instruments into the collecting system. Using the flexible ureteroscope, we identify the optimal posterior calyx for renal access. The choice of calyx is critical, especially in complex cases like staghorn calculi, as it dictates stone clearance efficiency. Once the calyx is selected, we insert the Retroperc puncture apparatus through the ureteroscope. This allows precise control of the puncture under direct vision, an advantage over traditional antegrade approaches. Under fluoroscopic guidance, the puncture wire is advanced through the kidney until it reaches the flank. Gentle forward pressure creates a skin tint as the wire approaches the surface. Once the wire emerges, we clamp it to maintain stability. The location of the wire exit is confirmed by palpation, ensuring precise alignment between the calyx and skin exit. The point A marks the 12th rib tip, and point B is the iliac crest. The area between these points, beneath the posterior axillary line, shown in red, defines the safe zone for PCNL access. After a sufficient length of the wire is drawn from the flank, a coaxial catheter is then advanced over it, while maintaining the ureteroscope in the calyx. Once the coaxial catheter is seen inside the collecting system endoscopically, the ureteroscope is retracted and the catheter is advanced until hubing the skin. The clamp is removed, and both the ureteroscope and the puncture wire are withdrawn, leaving only the outer coaxial dilator and ureteral access sheath in place. After introducing a new working wire anterogradely, the coaxial catheter is removed, establishing through-and-through access, allowing the surgeon to proceed with renal dilation using their preferred approach. In another patient case, where interventional radiology has established a nephrostomy, but the selected calyx isn't ideal for surgery, preoperative CT scan and pyelogram should be carefully reviewed. The endoscopic view is utilized to identify a more suitable posterior and inferior calyx for access, allowing continuation with the antegrade approach. If the wire does not exit at the optimal position, it may be repositioned, especially if it is palpable subcutaneously. For example, if the wire emerges too close to the iliac crest, dilating at that angle can be challenging. In this situation, palpating the wire within the subcutaneous layer allows for a small, more cranial incision. By creating a path in this plane, the wire can then be redirected through the higher incision. This adjustment is sometimes necessary for obese patients, establishing a tract that is perpendicular to the calyx rather than tangential. This is the final appearance after the treatment, just before the renal sheath is removed. The total operative time was 105 minutes, with access achieved in 23 seconds under fluoroscopy. The patient was discharged within 24 hours, free of complications. The endoscopic retrograde access technique enables urologists to independently perform renal access without relying on interventional radiology. This intuitive and reproducible procedure has the potential to increase the adoption of PCNL among urologists. It facilitates precise calyx selection, crucial for complex cases, while streamlining the procedure, reducing anesthetic use, and shortening hospital stays by combining access and stone removal in a single session. Although data remains limited, a prospective trial is currently underway. In conclusion, the endoscopic retrograde access offers an innovative retrograde approach for renal access during PCNL, delivering precise control and improved outcomes while reducing costs. It lessens dependence on interventional radiology, potentially enhancing access to care, particularly in areas with limited interventional radiology services. Further studies are needed to establish the long-term efficacy and safety of this promising technique. Thank you for watching.